Hi everybody. We're just we're going to kick off in about 5 minutes. We're just going to give people who have to go through the registration process an opportunity to do their registration. So we'll kick off at 5 past, if that's okay with everyone. For those of you that have joined us, we are just waiting for everyone to go through the registration process, and we're hoping to kick off at 5 past. So if you could just bear with us. All right, welcome everybody. Tēnā koutou, tēnā koutou, tēnā koutou katoa. It's fabulous that you've managed to join us for this Q&A session on the Serious Illness Conversation Guide. My name is Leigh Manson, and I'm the program lead for Advanced Care Planning and Serious Illness Conversation Guide program at the Commission. I'm wondering if we could ask Lynn, one of our panelists, to start with the karakia. Lynn?
Thanks. Tū kua taku wairua, ki rere ki ngā taumata. Hei arahi I aku mahi, kia mau, kia ita, kia kore, ai e naru, kia pupiri, kia whakamaua, kia tina, tina, homee, huie, taikie. Let my spirit ascend to the topmost summits as a guide for all that I do. Keep it safe so that it will not be lost. Preserve and maintain it. Join, gather, intertwine.
Thanks so much, Lynn. All right, Mohammed, if you could move to the next slide. Thanks, Mohammed. Maybe before we start, I could, excuse me, introduce you to our panel. We have the Serious Illness Conversation Guide national trainers on the panel, and they were all involved in the development of the training video, which I'm hoping most of you have had a chance to have a look at. So on our panel today, we have Jane Goodwin, Dr. Lynn Twigley, Dr. Oleg Kiriaev, Carla Arkless, and Dr. Prue McCallum, and we'll be calling on them to answer your questions when we open up for Q&A later. So I wanted to ask for all of you to be kind to us. This is our first webinar ever. I've never used this technology, and all of us are feeling a little bit rattled about how this is all going to go. So we're hoping you give us a bit of leniency around the technology. All right, so how we are hoping to run the session today. So we're going to start with Jane Goodwin, just sharing a little bit about the guide, just for those of you that didn't have an opportunity to watch the training video. And then we're going to open to Q&A, and we're going to do that in a structured way. We're going to be asking you to send questions now. So if you have some questions already from watching the training video, please send them through, and we'll address those as and when we get to the Q&A section. Jane, so if you're ready to go, I'm going to hand over the reins to you.
Kia ora, Mohammed, could we have the next slide, please? So next one after that probably is what we're wanting to have up. Thank you so much. So a little bit of a background and introduction to the Serious Illness Conversation Guide. Why, I guess lots of people are wondering, was the guide developed to start with, and really it was created in a response to hearing healthcare professionals saying that they were feeling ill-equipped to have these conversations with seriously ill people about what they want if their lives were limited. And we know that individuals who have conversations with their clinicians about their values, goals, and wishes are more likely to receive the care they want. They have fewer non-beneficial medical treatments, and they also generally report a better quality of life. So the Serious Illness Conversation Guide was created by a team of palliative care experts at Ariadne Labs in the States, and it was designed as a system-level intervention centered around the Serious Illness Conversation Guide structured questions, which come from best practice and basic palliative care. It serves as a framework for clinicians to explore topics that are crucial in gaining a full understanding of what's most important to patients. So when you look at the Serious Illness Conversation Guide, you see that it's a list of patient-centered questions, which are designed to assist clinicians in gaining a more thorough understanding of their patient's life in order to inform care decisions. And in this way, it's really a focused advanced care planning discussion at a point where something is changing with that person's health. What it helps us unpack is the person's understanding of their illness, their preferences for information, their personal goals, their fears and worries, and information around the abilities they find most important to their daily life and the trade-offs they might be going or willing to go through for the possibility of more time. And we know that when we're faced with stressful situations, like having this kind of conversations with our patients or their whānau, that it really helps to have language to turn to in order to make sure that we're covering the key questions, and it also makes sure that we're able to address the important issues in a patient-centered and efficient way. Next slide, please, Mohammed. Excellent. So I guess when we think about the Serious Illness Conversation Guide, we've been using it here in Aotearoa, New Zealand for about the last 18 months. And the document you've just seen on the previous slide was our Aotearoa version, which we created with support of consumers and clinicians around the country to help us adjust the language to feel relevant to our country's context. And in the 18 months that we've had this up and running, we have seen clinicians successfully navigate these conversations and grow in confidence having these conversations, particularly if they're not discussions that they've had a lot of opportunity to do previously through the use of the guide. And this is because they're consistently sticking to the guide, saying the words, acknowledging emotion, agreeing a plan with their patient, and documenting it, writing it down. Next slide, please. So with COVID forefront in everybody's minds, and off the back of some feedback, we've had some of our colleagues in other countries who are further in the, I guess, in the glut of the COVID environment. We have decided to create 2 further documents to support our suite of documentation around Serious Illness Conversation Guide. And that is alongside our Serious Illness Conversation Guide Aotearoa, a Serious Illness Guide for the COVID context for COVID patients, and the Serious Illness Guide for whānau, particularly when we're having COVID conversations with them, updating what's happened with their loved ones. So the COVID version of the Serious Illness Conversation Guide, which we're going to look at in a little bit more detail shortly, but essentially it has more detail down the left-hand side to help clinicians navigate the conversations. And we've tweaked the prognostic statements more specifically related to COVID-19 responses. The Explore section has been shortened. It's become more focused, recognising that clinicians may be more time poor and also that patients may have less physical abilities to answer the questions. Having said that, if you do have capacity to do more of the Explore, that's really useful. In the COVID Serious Illness Conversation Guide, our final section contains 4 different suggested plans which link back to the goals of care categories that we use in the National Goals of Care documentation. Then the Serious Illness Conversation Guide whānau COVID version is aimed at supporting the conversations often that we might have to have by phone with the whānau of people that have a positive diagnosis to help them gather more information about the person, their preferences and priorities if we can't elicit that information from the individual themselves. Next slide, please. So let's look at these in a little bit more detail. Serious Illness Conversation Guide Aotearoa. This is the first of our guides, as I said. And in the context of COVID, this is the guide we'd be using for patients that don't have a positive COVID test, but do have a serious illness. We know that our patients with chronic conditions, with serious illnesses, that hasn't suddenly evaporated in our current environment. It's still there, it's still existing. And this, we're using the Aotearoa guide to support the conversations with them about their preferences and priorities if they did become more unwell. That may be through a progression of their current condition, or we also probably recognise that these patient groups are often at more risk of potentially developing COVID. When we think of the DVD example we saw, or we released on Monday, it's probably, you saw this in action with the Lynn and David conversation. So Lynn used the Aotearoa Serious Illness Conversation Guide to explore David's preferences for care going forward. And she did need to field some questions around how that might look or why we were having these conversations and was it COVID related. Next slide, please. The second in our suite is the Serious Illness Conversation Guide in the COVID positive patient. And one of the reasons that the work has happened in the space, and you can see those aspects I highlighted earlier around the difference in our prognostic giving and our sharing section, we've been quite explicit about things like time in this zone because we're hearing that things happen quickly. So that's part of that conversation and that discussion you can see when you look more closely at how we share information and then how we might pull some of that information together in a recommendation. Okay, next slide, please. The third in our suite, looking in a bit more detail, so you can see it up on the screen, is the whānau version for patients that have tested positive to COVID. And you'll see there that it's very similar to the Serious Illness Conversation Guide COVID version, but we've just changed some of the language to recognise we're speaking to whānau rather than to the individual themselves. It also highlights in this section information around the fact that when we're giving information and we're making decisions around our discussion, that the whānau member is providing us with preferences. They are not the person making the decision for that individual. And I guess, although we haven't got it in the suite per se, you might have noticed when you watched the training video that there was a third example of a third DVD in the mix. That was with Tammy, one of our clinicians working out in Nelson, and she was having a conversation with a whānau member. She used Aotearoa SICG, but she was using it in the context prior to COVID of exploring preferences from whānau about what the patient might have wanted in their situation. Next slide, please. Okay, Leigh, can I hand over to you now?
Sure, thanks, Jane. All right, so this is our opportunity to start taking questions from the floor. And I'm wondering, while that we wait for some of those questions to come through, maybe a sort of general comment from our panel. Oleg, how about if I start with you?
Thanks, Leigh. So I guess my initial thoughts really are that I believe this guide works best if it's clinician initiated. So it really has to be something you have to be prepared for and decide you want to do before meeting up with the patient or their whānau. It's important to be aware of the opportunities in what the patient says, as this could potentially frame the guide in a way that they would find useful. Often we wait for these conversations to be initiated by patients, and the research definitely shows that patients expect the health provider to actually solicit such conversations, because if we wait for them, then it risks it often being too late in the greater scheme of things. Yeah, so I think having it front and center of mind and being opportunistic are really important in order to implement the guide.
Thanks, Oleg. Awesome. Okay, so Mohammed, if you could go to the next slide, please. Right, so I'm interested in any questions you have about preparing for the conversation. Alrighty, so, all right, question. Shouldn't we be doing this for all our conversations? I'm wondering, Carla, do you want to take that one?
Sure. So, yeah, I guess the concept of preparing for this conversation is certainly similar to preparing for any clinical consult. But I think the thing to remember about this is identifying patients who we should be having this conversation with. So in particular, those who have or suspected of having COVID, but also those who are at risk of deteriorating from other conditions, either imminently or at some point in the future. So yeah, it's something we need to be thinking about, the prioritizing which patients we're going to be having the conversations with and who is going to benefit most from these conversations.
Thank you so much, Carla. All right. So the next question, I'm an OT. Am I the right person to be leading this kind of conversation? I'm wondering, Lynn, do you want to take that one?
I think one of the things that often we hear when we're doing the training for this conversation guide is that people feel really uncomfortable that this might be something new or out of their usual scope of practice, or they feel worried that they're not the right person to be having this conversation. And one of the things that comes to mind really is, I guess, what Oleg talked about in terms of opportunity and kind of being opportunistic. And I think that if you're someone who is in the role of working frequently with seriously ill people, then that means that you do have that opportunity. And one of the things to reflect on is, you know, does this feel like it's within my scope of practice? It's very important that we recognise that these are not conversations that only need to be done by doctors or nurse practitioners. These are conversations that are safe and can be very well achieved by all members of the multidisciplinary team, including allied health pastoral workers. And I think the beauty of the guide is it gives us some options in the prognostic statement. That's often the bit that feels really sticky to people who maybe aren't so used to having these conversations. It gives us some options of ways of framing the prognosis that might feel more comfortable in our role. So if you look at the guide for Aotearoa, there's those options of mentioning that someone's future is uncertain, or mentioning that things might be as good as they're going to get and are likely to get worse. And those statements feel comfortable to all people who work with seriously ill people, and that sort of gets us out of that worry that I can't do this. The other thing to really hold on to is that what we're really doing here is we're listening. We're exploring, we're asking questions of the person, and that's something that, you know, we are all able to do. I think when it comes to the recommendation part of the guide, the other thing that I encourage people to think about is that that's open for you to use your scope of practice to personalise the recommendation, and it's perfectly okay if it feels like there's other conversations that other people in your team might then follow on with information that's not usually your field of expertise that you can say. And one of the things I think would be helpful now is to have a conversation with XYZ and offer that other member of the team.
Thank you so much, Lynn. Alrighty, so next question. Many of my patients don't have English as a first language. Suggestions for how I do this with them. I'm wondering, Prue, do you want to take that one?
Yeah, sure. So these are difficult conversations, aren't they, at the best of times, and even more difficult in a second language. This really brings to mind also the role of the interpreter. So we might talk about using family as interpreter, but if you are going to use an trained interpreter, you probably just need to check your local DHB or hospice policy first. If you're in a situation where you're not using an interpreter and you're going to use a family member, I think it's really important to just recognise how challenging it can be for you and for the family member, and indeed for the patient, and acknowledging that it's even more complex when these conversations are taking place by phone or by video. So if possible, it's really good if you can talk to the family member first and just check their understanding of the situation and of any words you might use. You can also run through the questions. You can run through the guide with them, run through the questions so they know what's coming. Because I think sometimes family members will help you and want to ask the questions, but as soon as they feel uncomfortable, they can derail conversations. So I think using a serious illness conversation guide, going over it ahead of time, then they realise what's coming and how it is patient focused. I think you also need to explain to the family member that you will be directing the questions directly to the patient and asking them directly. And what you're asking of them is to ask exactly the same question in their language to the patient. So you are going via interpreter, but you're not going doing a two-step. You're actually just focusing straight on the patient and they're echoing you. Really important at the end to check understanding of from both the patient really back through the interpreter, and then at the end to thank the family interpreter, because we put them in a really difficult position.
Awesome, thank you so much, Prue. Alrighty, why do you have treatment options in the picture? So in the picture there, we've got treatment options. Jane, do you want to take that one?
Yeah, I guess we often think about the treatment options being kind of at the end of the conversation when we're pulling together our recommendations. But I think it's a really, really useful thing for clinicians to do as they're preparing to go and have this discussion, to think about what's going on with that person, what's happening in there from a clinical perspective, and what treatments are available and medically appropriate for them, even if they were saying, I want the kitchen sink thrown at me. So it's really useful to have done that thinking up front, to know that if there are some things that they might be requesting that aren't on the table, it helps us to navigate that conversation with some confidence. What I've seen in my 6 or 7 years having these conversations clinically and supporting clinicians to do this clinically, if they haven't done some of that thinking about what's medically appropriate and indicated up front before they get into the conversation, they can find themselves offering or agreeing to a whole lot of treatments that may not be appropriate for that individual. And then there's a real difficulty in terms of who unpacks that, who goes back and says things are different. So discussion up front, and that might be a team discussion. Actually, that's really useful if you're having these, where are we up to? What are our goals of care from a clinical perspective for this person, so we know what's on the table.
Awesome. Thank you so much, Jane. Mohammed, I'm wondering if you can go on to the next slide. I think we could move on with the parts of the conversation. Alrighty, so thinking about the conversation itself and the component parts of that and the component parts of the guide, starting with setup. Prue, could you remind us, what are we covering off when we're setting up the conversation?
Right, so before we have this conversation, we need to establish rapport with the patient. So there's, so maybe someone else could talk about the whole establishing rapport part of it, and I'll just talk about the setup. So once we've established rapport, it's really important to explain why we're having this conversation. It needs framing. So for example, the words in the guide are, I'm so sorry that we're in this situation. You then need to probably acknowledge that it's not a very easy conversation to have via phone or video, and then to explain the benefits of the conversation and ask permission to go on. So that using the words in the guidance to make sure that you have the best care possible. To do, we want to make sure you have the best care possible. To do this, it would be good to talk about what is happening with your health, what might be ahead, and what is important to you. So explaining why you're doing it, and then you say, is that okay? So that's seeking permission to go on. And then, when appropriate, asking if someone else needs to be there, present for this important conversation, even if it's by phone. So that's the setup after you've established the rapport.
Awesome, thank you so much, Prue. I'm wondering if you could also talk about whether you need to be varying your approach to these conversations, particularly now with the pandemic and having to have these conversations on the phone or via video conference. Because you did mention that. Do you want to maybe explore that a little bit? That's another question that's come through.
So sorry, the question is whether it's different from the standard serious illness conversation?
No, just to think about what we need to keep front of mind, because when we're having these conversations over the telephone or on video conference instead of face to face, things for us to take into consideration.
Yeah, so I did mention it, how much more difficult it is and how stilted it is. And so one of the big missing components when you're doing things on the phone or via video is the non-verbal aspects of communication. So those of us that have these conversations rely on non-verbals, leaning in, eye contact, perhaps the right sort of touch, proximity, and all those parts of communication are so important. In fact, non-verbal make up about 70% of communication skills. So we need to compensate for them when we're talking on the phone or on a video. So we do that by using tone, allowing silence, because we don't have the cues when people are speaking. So we've got to be very careful not to interrupt. We just have to be more mindful. And I guess really none of us are necessarily particularly skilled in this, and maybe we get better with time.
Absolutely. Thanks so much, Prue. And I think we saw demonstrations of those in the videos that you guys did, the conversation demos that you guys did in the training video. I think that the tone of voice, leaning in, even the eye contact via video is still possible. It's not ideal, but it is still possible. Alrighty. Let's see. Comment here about an emotional and personal conversation. How do we do this in a culturally safe way? And Prue, you just mentioned a moment ago talking about whakawhanautanga and others. I'm wondering, Oleg, do you want to take that question?
Yeah, thanks, Leigh. So I think it's become apparent in this crisis, in this coronavirus crisis we're currently living in, that, you know, it's demonstrated like nothing else that we in actual fact do live in a multicultural world. But that despite this, I think it's also shown that there's so much more that we all share in common and connects us than there are differences that separate us. I think as clinicians, we're all aware of the importance of culturally appropriate practices. In the main problems we face, really, how do we actually deliver that effectively? The most important lesson I've learned over the years is to first understand and embrace my own culture, and it's from this basis that I can then reach out to others and appreciate others better. We have to acknowledge our own perspectives, our own beliefs and biases, and I know the Commission has excellent resources on this topic, which I would refer you to. And with this, we can then reach out with whakawhanaungatanga. And remember, it's about developing a connection with that individual and their family, and they will guide you in terms of what's best practice for them, be it a prayer or a karakia, or any other considerations you need to incorporate into your practice that they feel is important. So I guess, you know, that really reminds me that I shouldn't be making assumptions about a person's culture. And I should always remember to ask first and seek permission if I'm unsure about what to do or how to behave. I really like the term cultural humility because it ensures I always make space for their culture, prioritize for their cultural needs over and above my own. And I think the model that the Commission uses is the hui model. And that's a resource freely available through their website. So I'd refer you through to that as well.
Thanks so much, Oleg. So just to clarify, the implicit bias videos that Oleg referred to are available via the Commission site, the Talking COVID site. There's a link through to them, as well as the hui model referred to is included in the clinical reference guide, which again is a resource you can click through to on the Talking COVID website. Alrighty. So the next one, in the demo videos, you're having these conversations with patients on their own. That worries me. All right. I'm wondering, Lynn, do you want to handle that one?
Sure. And I acknowledge that that can feel really uncomfortable when we know that we're talking about things that can bring up, you know, strong emotions for people. So it feels really important that we're giving proper opportunities for people to link in with their loved ones, whoever they want on the call, with digital means. So if it means that we have to pause so that that can happen, that's really important. The other thing that, you know, I find sometimes in having these conversations with people is that, you know, that might be the person's choice, that they want to hear this first themselves before they share with their loved ones. And the reality is that some people don't have someone that they are able to invite into this conversation. And in that situation, I think the thing that is very important for me is to remember that actually the person isn't alone and that I'm there with them. And it's really important for me to offer my attention, my empathy, my presence. That's the thing that I try and hold on to when I'm having a conversation with just one person, is that we're in this conversation together, person to person. And it helps me to remember that although I'm coming from a clinician's perspective and I have some expertise in those aspects, I'm meeting with someone who, and I'm wanting to know about the person's expertise in them and what they value. We are you know, we are two human beings in a tough situation together, particularly at the moment. I think the whole world recognises that we're in, you know, in this boat together. So that's something that I find useful to hold on to when I'm speaking with someone who doesn't have someone else in the conversation, is we're in this conversation together. And I think that presence is I've heard people reflect that that's really comforting to them, just that you listen. The other thing that I do, you know, really concentrate on is when I've had a conversation with someone who's by themselves, is to encourage them to think about who they'd like to involve in subsequent conversations. So it's certainly something that I would, you know, really try and advocate for with the person, is who else really, you know, needs to know about what you're thinking. Yeah.
Thank you, Lynn. Thank you. Mohammed, I'm wondering if we could move on to the next slide, please. So this is a particular area where we know you're going to have some questions on around the prognostic statements, particularly the different prognostic statements across the two guides, the Aotearoa and the COVID guide. So Mohammed, I'm wondering if you go to the next slide. We've split that out so that everyone can see both of them, one alongside the other. Jane, did you want to sort of highlight the key sort of differences and why they're there for us, please?
Absolutely. So I think we talked earlier, I think it was Prue that talked about the different sort of, or prognostic given, and how we in the Aotearoa SIG use sort of three key sort of frameworks. For someone that has a uncertain prognosis, for someone that we want to give more specific time-based prognostic information to, or for people where we're talking about function. That I hope this isn't the case, but I'm concerned this might be as well as you feel. So those are sort of the traditional framework. When we've looked in the COVID context, or thinking about having these conversations with a patient that has COVID, we've reframed those a little bit in terms of what our expectation is for recovery. So if recovery is hopeful, we've put some words in there around sort of where we're up to. It can be difficult to predict what will happen with your health. I hope that you will continue to do well, but it is possible you could become more unwell quickly, and it's important to prepare for this possibility. We've also got a more uncertain recovery prognosis, which says, I hope this is not the case, but I'm concerned that you might not recover even if we give you all possible treatment, and that you may deteriorate quickly. Or the final prognostic we've used in the COVID version is around if we think death is likely. I wish this was not the case, but I'm concerned that time may be as short as, and then we can give our time frame in that situation. The final statement from whichever of those prognostic options you choose is that acknowledging that I know that this mightn't be what you wanted to hear, and I'm so sorry we're in this situation. So you can see we've kind of used a similar structure, but in the context of recovery and what we're thinking might happen for that person.
Thanks, Jane. So why the focus on quickly? Isn't that going to freak people out?
Yeah, really good question. And actually in our initial take, and when we pulled this together, we weren't so explicit about things changing quickly in hopeful recovery or in our uncertain recovery. But the feedback we got from some of our colleagues that are in the thick of this work at the moment in the States, particularly Dr. Josh Lakin, who has done a lot of the training with us locally here to deliver and train the guide. He said that they're finding on the floor that things are happening incredibly quickly for people, and you can have the conversation and within just sort of half an hour later, things have changed dramatically for that person. So they, in their practice, have found that they're needing to be much more explicit to say, although things are okay at the moment, or we're not sure, things might change really quickly, to give people that heads up, not just for their preparation, but they're also saying too, they're really saying, don't leave those conversations to have with family and whānau till later. If people are wanting to have conversations, if that's a priority for them, they're saying you need to get on the phone and do that now, or we'll hook you up with the web link and you can have that conversation now, because we're sometimes not having that opportunity if we leave it.
Thanks, Jane. Alrighty, so next question. if recovery is likely, why are we having this conversation? Carla, do you want to tackle that one?
Sure. So I guess it's really tempting, isn't it, to think, okay, we're in a safe zone. This person, we're pretty sure this person's going to recover. We can avoid the tough conversation, but you know, there's so many factors at play, and even if we do expect someone to do well, sometimes they don't. We know this. So to have an idea of what would matter most to the person if the unexpected happens and they do start to deteriorate, at least if we get some idea up front, we're not having that conversation for the very first time in a crisis, or at the actual point where we need to make rapid decisions. We don't necessarily need to talk about specific treatment decisions in the event of deterioration. That's not the focus. The focus is on what their priorities would be, so that if we are in a situation of having to make decisions, we've got a starting point. We don't have to start way back at, well, what are we trying to achieve here? We've already sort of got a sense of that if we do need to make some decisions in the future. So I think, yeah, it's really important to be prepared, even if it's hopeful that they're going to recover.
Thank you, Carla. So the next one is, when would I use the top one? I assume Aotearoa guide. Jane, maybe if you wanna have a go.
Yeah, so I guess what we've already sort of mentioned is that people haven't stopped being sick or haven't stopped having their other conditions just because we're in the COVID crisis. And I guess this is an opportunity, using the top guide, the Serious Illness Conversation Guide Aotearoa, and one of those 3 prognostic statements is for our patients that have got other stuff going on for them, but it may not be specifically a COVID thing that's going on for them. So when we think back to the DVD, that would be the discussion that Lynn had with David. It was his bowel cancer that was happening, that she was most concerned about, but she was also aware that there was risk that he might be at a higher risk of developing or being susceptible to significant COVID impacts if he was to catch it. So I guess it's a way of, as Carla said, doing some preparation up front when it's not such an acute situation, whereas our COVID SIG is much more, we're in it now, things are happening quickly, and we just need to be very clear with what our requests and where we're up to.
Thanks, Joan. I think that clears it up nicely. So one of the things that we've seen when we've been training across the country before we developed the training video was the sort of uncertainty about, do I need to read all of them? So I'm wondering, maybe Oleg, you're nodding. Do you want to maybe address that one?
Yeah, thanks, Leigh. I'm really glad you asked that question. So yeah, I've seen that happen as well, and I've seen that mistake being made sometimes with people using each of those statements, each of those prognostic statements, one after the other. So I guess that really demonstrates why it's so important to become familiar with using the guide and having an ability to navigate those different prognostic statements. And that's also why it's important to actually prepare yourself before seeing the patient, because ideally what you really want to do is to have a sense in your mind which of those statements are you going to want to use. Are you going to want to use the function one or the time one? And being prepared in that regard. Obviously, through the course of conversation, you might well need to change your mind in terms of which one you want to use and be adaptable in that regard. But yeah, I think the key message really is preparation and picking one or the other, and having a sense, you know, where that person is. Yeah.
Thanks so much, Oleg. Alrighty, so another question. I don't like the trade-off question. It feels uncomfortable. Lynn, you look like you want to take that one?
Sure. So I guess when we're
looking at doing something new, some parts of it often feel a lot more comfortable. It's like sort of putting on someone else's clothes, really, isn't it? Sometimes they fit, sometimes they don't. They don't feel that comfortable. And it's the same with the questions in the explore section. Some of them feel you know, more challenging to ask, or maybe, you know, do I really need to ask that in this situation? The way the guide's been developed is very deliberate, and there is an ebb and flow in the questions, where the guide takes us through questions that can be a little more challenging, a little bit more difficult for patients, you know, in terms of perhaps what's worrying them, and then also chances in that section for people to think about the resources and the resilience and the strengths that they have, or the things that are more positive that they're considering. So there is a real purpose to having those questions. And I guess it's a little bit like Oleg said about the humility piece, and that when I'm exploring with someone what's important to them, I'm really trying to acknowledge that I haven't got a clue which things are going to chime with that person, what things are going to really be meaningful for them. So it's very important to not assume, to not prejudge, just to work through the guide as it's written. And some people will skip over certain parts with a short answer because it doesn't mean much to them. And another thing, maybe unexpectedly for us, will be incredibly important. So I think there's great value and also safety in just following, say the words, follow the guide, flow as it's written. And particularly in the COVID context, it really can give us a lot of very helpful insights about what's ahead for that person.
Thanks, Lynn. I'm wondering, Mohammed, do you want to move the slide along? Because I know that we've got a slide coming up with the explore questions on it, which would be useful just to have it in front of us. One more, please, Mohammed. Just because we seem to be, we seem to be addressing some stuff there. So, Prue, did you want to add anything to what Lynn was saying? I saw your hand up.
Yeah, no, I did want to add something, because so it's I think people find on the whole it's quite a lot easier to ask what your priorities are if your health gets worse, or what worries you about your health changing. It's probably more difficult to say what abilities are so important to you that you can't imagine living without them, or how much more are you willing to go through for the possibility of more time. But I can think of a couple of specific examples where these could be useful at the moment. For example, what abilities are so important to you could relate directly to the cognitive decline associated with intubation and respirators and ICU admission. And if people understood exactly what that meant, it may be that they're not willing to go through something like that. Another example of a trade-off would be at the moment staying at home versus going to hospital alone without visitors. So each of the questions really just asks a little bit more from a different angle in a different way. So they all paint a picture of what's important to the patient. So I think they're all useful.
Thank you so much, Prue. Mohammed, I'm wondering if we just move on a little while. I do realize time is ticking. So if you could go, so maybe to get to the close part of the conversation. Thank you for bringing that up. Jane, do you want to just run us through the sort of differences? You can see that COVID is quite different. I'll leave it for you to share that.
Yeah, thanks, Leigh. I think I alluded to it when we did the sort of high-level overview up front, but we do have some significant differences from our Aotearoa Serious Illness Conversation Guide to the COVID version. In the Serious Illness Conversation Guide Aotearoa, you can see at the top of the slide there that we really use this as an opportunity to pull together what we've heard from that person and to make a clinical recommendation. And in the Aotearoa version, there's quite a lot of scope for that clinician to tailor that recommendation to not only what is clinically appropriate for that person, but also for their sort of scope of practice. So if they maybe are an allied health worker, it might be actually, I think we need to be having more conversations with your team about some of these things you've told me are important. It might be recommendations that this information you've told us is really valuable, and potentially we should be thinking about capturing some of it in something like an advanced care plan going forward. So those is, or it might be that we need to have further conversations with whānau to be supporting this conversation. Or it might be the start of further conversations. Actually, we need to talk more about your thoughts around resuscitation or specific treatment interventions. So that's our sort of Aotearoa version, the top bit. When it comes to the COVID version of the Serious Illness Conversation Guide, we have chosen to align our recommendations much more closely to the shared goals of care documentation that has started to be rolled out across the country. And that is looking at a restorative approach with maybe some limitations in terms of things like resuscitation, or a more quality of life, or supporting a natural dying process. So we've got a slide coming up shortly that shows how those sit more closely aligned with those prognostic, or those recommendations that we're suggesting in this context. And I guess that's because we're thinking specifically for COVID, we are needing to be much more succinct with our recommendations and giving that oversight and guidance to the clinicians that might be following on with this care.
Thanks so much, Jane. Mohammed, I'm wondering if you could just move, I think it's 2 slides, where you have goals. One more, please. Mohammed? There we go. So there's the shared goals of care form that Jane was referring to. And if you go one more slide, Mohammed, we can see the alignment of, Mohammed, one more. There you go. There you can see the alignment of the closed section of the COVID Serious Illness Conversation Guide with the shared goals of care that Jane alluded to. So Jane, here's a question from me, or maybe give Carla a chance. So Carla, question from me. We say we're going to do everything, but we know we're not, yeah?
Yeah, look, it's something that many of us worry about because we don't want to create unrealistic expectations. So if there's a feeling maybe that we're giving some people carte blanche to say, I want X, Y, Z, and we're going to provide that. But what we're actually saying is that we'll do everything we can. So that means everything that's clinically appropriate. So that's not everything that's scientifically possible or available in the world. It's about what is clinically appropriate for this situation, for this patient at this time, and what's possible in terms of service provision and resources. So yeah, we're not offering everything in the whole wide universe.
Thanks, Carla. So Jane, you got your hand up. Do you want to add something?
Yeah, I guess just the next step from that, I think Carla summed it up beautifully, but it's also recognising that everything we can do at one point in the COVID response might be different than it is down the track. And so by not promising specific treatment interventions, by promising sort of a goal of care or suggesting a goal of care, we as clinicians have got flexibility to be moving around what we then are able to offer. So it gives us a little bit more scope, rather than if we'd said, yes, we'll definitely put you on a ventilator, and then the resources for that might become more challenged. We don't have to be having the conversations about the specifics at this point quite the same.
Thanks, Carla and Jane. So one of the things that we hear often when we're looking at these guides is that it feels like we're not giving the person all the information and the options to choose from, sort of that they might not understand what they're agreeing to. I'm wondering whether maybe Lynn, do you want to address that for us?
Yeah, sure. And I think it's very important to actually acknowledge that this guide is not going to cover every conversation in every situation. So what we're really trying to do with this guide is to give the person a sensitive heads up about their situation, and then to discover from them, to explore with them what their priorities are before we get into that nitty-gritty of perhaps, you know, treatment options and plans. And the order of that is really important, because if people don't understand the relevance of those treatment choices to them, we can end up having very kind of surreal or esoteric conversations about sort of treatment menus when people don't appreciate how they might apply to them. And also, if we listen first of all to what someone's goals of care are, a lot of the treatment decisions may fall out of that conversation just by listening. So it avoids us having to go into all sorts of conversations that actually might not be necessary, because the patient already tells you how they feel about some of those things. That's not to say that in other situations we don't need to carry on to have more conversations about specific treatment options to clarify people's understanding of those and how they might apply, and whether or not that's something that's going to be available to that person. So those are the follow-up conversations. And I guess the urgency of how quickly those conversations follow on depends on the context. It depends on whether we're having conversation, you know, aotearoa with someone who's got serious illness but is not at the moment in a critical situation, or whether we're having a COVID conversation where we see that someone might deteriorate, as Jane says, in a matter of hours. So how we follow up on the conversations depends on the context that we're in at the time. Yeah.
Thanks so much, Lynn. I'm wondering, Mohammed, if we could maybe move on to the next slide and go to some general questions. So one that's come through, can we start using it now? Jane, I'm wondering if you take that one.
Absolutely, we can. Obviously, in an ideal world, if we weren't in the midst of COVID crisis, we would be saying it would be great to do some training around this. And we do have the 3-hour workshop, which is clearly something we can't be delivering at the moment, given our current lockdown restrictions. Hence the DVD that we've created to give you guys a bit of a flavour and a heads up for what the guide is and how it might work, and some opportunities to see some examples of it in action. But absolutely, get out there and use it. We have an example where I'm based, Waitaha, Canterbury. The COVID wards that are being opened here, they're actually Rachel Wiseman, who is the consultant supporting those wards, is using the Serious Illness Conversation Guide to be framing her conversations with patients in that context. And we're introducing the Shared Goals of Care documentation, hopefully imminently today or tomorrow, to be helping support the capture of those conversations as well. So yes, out there using it. We had feedback from a registrar that was working on the COVID ward over the weekend to say that she'd used it after seeing Rachel's example and how valuable and useful it was, and way easier than I thought, and it worked really well, and I got great feedback from the patients. So give it a go, absolutely. And I think there are opportunities to do some practicing to get your tongue around some of the words. And I know that at the end of the DVD, I think we've got some links. One of them is to a sort of I'm lost for the words, guys. What's the word? What do we call it? The drill section. That's what I'm after. The Serious Illness Conversation Guide drill that you could actually just, you know, find a friend, find a buddy, one of your clinical colleagues, maybe just read it through with them, just so you've had a chance to get your tongue around the words before you have a go with the patient.
Thank you, Jane. Mohammed, I'm wondering if you could go to the last slide, and we'll just ask each of the our panelists to give us some concluding remarks. Alrighty, so Lynn, you happy to go first?
Sure. I guess one of the things I really want to share is that recognition that we're all in a difficult time at the moment, and many of us are feeling overwhelmed, many of us are feeling anxious, and also we're soaking that up from the patients and whānau that we work with. And I think it's really important at the moment to remember that to be kind to ourselves. We are asking you to do something that's new. These can be difficult conversations, and it's really important to remember it doesn't have to be perfect. I think that's one of the things that as I learned to use this guide, many times I thought, oh, you know, I should have done this, or I can't believe that, you know, I do that when I'm talking. And yet it was good enough and it got the job done. And also I think at the moment it's an enormous gift that we have to be present for people. We're all feeling often quite powerless at the moment, but just by listening and helping people think about what's important to them, you know, we are doing something to help. So be gentle on yourself after having these conversations. Make sure that you're nurturing your own spirit.
Thanks, Lynn. All right, Oleg?
Yeah, thanks, Leigh. And I'd just simply like to echo what Lynn's already mentioned. These can be difficult conversations, and we are asking people to, you know, really touch upon and talk about some very personal and private aspects of their lives, and this places them in a very vulnerable space. And as clinicians, we often do find we struggle to support them in that space. But don't let that prevent you from actually having a go and having a conversation. The guide is there to help support you with such conversations. And I recommend you simply just need to get out there and give it a go. And if it is your first time, you know, I recommend please take the guide in with you during the assessment and let them know that you'll be using it to support the conversations, to make sure that you're able to do the best job possible and that you don't leave anything important out of the conversation. Just simply give it a go.
Thanks so much, Oleg. Carla, you're up next.
Okay, I guess just a very quick reference to having these conversations over the phone. Just to add to what's already been said, I think we don't need to change the guide. We can absolutely use the guide exactly as it is over the phone, with the addition of acknowledging that it is more difficult over the phone, so acknowledging that with the patient, but also with dealing with emotion, we can't see people, so we might just have to ask how they're feeling. I'm just wondering how this news is, how you're taking this, or how you're feeling about what I'm saying. You might have to physically actually ask that and acknowledge and ask, is it okay if I continue? Especially if there's silence on the other end. So what we would normally observe, we might just need to put into words.
Thanks so much, Carla. So the next one up is Prue.
Hi, okay, so my last words would be to use the words on the guide, follow the order, it makes sense, it's a safe tool and it works. And secondly, alongside the words on the guide, respond to people's emotion. So just do it in an empathetic way, responding to the emotion on the way through.
Thank you so much, Prue. All right, Jane. So a little wrap up from you, please, and then we'll have Lynn say a karakia because I know we are out of time. Thanks, Jane.
So I would just like to echo all my whānau panellists' comments, and the last bit that I'd like to add to the mix is remember to write this stuff down. It's really important that if we're having these conversations and if we're hearing this really important information, this vulnerability from our patients, we're in that space that we need to capture it and document it. It might be that if you take the guide in, you actually make notes on it that you can use as a reference. It might be thinking about whether we complete the shared goals of care documentation. It might be that your local organisation has somewhere to capture and put it, but please do your best to capture this so these important conversations aren't lost in the ether and people know where we're up to and can follow on efficiently and effectively. I just want to thank everybody so much for their time today, for taking an hour out of practice, which I know is a really big deal in our current climate and environment, and for the great questions that have come through. We really appreciate it. We really appreciate the time and energy people have put into creating this resource, but also to viewing it and coming with such thoughtful and great questions to the mix. So thank you so much, everybody. We hope you stay safe out there. Kia kaha, and I will hand over to Lynn for our closing karakia.
Thanks. Kia whakaria te tapu, kia wātea ai te ara, kia tūriki whakatahi ai, kia tūriki whakatahi ai. Haume e, hui e, taiki e. Restrictions are moved aside so the pathway is clear to return to everyday activities. Go well, everybody. Stay safe.